European School of Oncology and ESMO, the European Society for Medical Oncology, hold a meeting every 2 years for guidelines, international consensus guidelines for advanced breast cancer in Lisbon in Portugal. And I am a member of that panel. We have 44 breast cancer experts worldwide. We meet every 2 years in Lisbon in Portugal, and we issue statements, guidelines, practical guidelines for physicians in practice to use to take care of patients with advanced breast cancer. That meeting actually has breast cancer experts of all fields, and also we have nurses and breast cancer advocates as well who are part of our panel. We met in November in 2017 for ABC4 guidelines. We publish the guidelines usually in the Annals of Oncology and in the breast, both journals. And we also tour the world, giving lectures on those guidelines. It is important that physicians hear the science, all the scientific presentations, but very often the clinicians want a guidance. There are no clinical trial for every particular patient. So this is why those guidelines are important. And here at this breast cancer conference, I presented a selection summary of those guidelines, general statements, as well as patients with estrogen receptor positive, hormone receptor positive, as well as some on hormone receptor, negative, HER2 negative, and also HER2 positive. And I will summarize a few of them for you. For advanced breast cancer, an important statement that we repeat, that when the patient has hormone receptor positivity, HER2 negativity, usually we should start treatment with hormonal therapy unless the patient has what we call visceral crisis, which means that the patient has advanced disease in the lung, in the liver, that is causing lots of symptoms and abnormal blood tests. Otherwise, if the patient has only 2-3 lesions in the lung or 2-3 lesions in the liver, there is no need to jump to chemotherapy. Hormonal therapy is usually easier, better tolerated, a much better quality of life for the patient. So we insist on that issue. Now we say postmenopausal women should receive aromatase inhibitors or tamoxifen or fulvestrant hormonal therapy as first line. And now the new data coming out, one of the most important advances in the treatment of breast cancer since trastuzumab for HER2 positive, is CDK4/6 inhibitors used in hormone receptor positive, HER2 negative patients with metastatic disease. So we use we have palbociclib, ribociclib, and now the abemaciclib as well. Those 3 drugs, we spoke about them. We think they are a very good, reasonable option upfront, first line for patients with metastatic breast cancer. And there was recently a study at San Antonio using ribociclib in the first line for premenopausal women. So now we issued a statement at the ABC4 guidelines that CDK4/6 inhibitors are recommended, good option for treatment in first line for all patients, whether postmenopausal or premenopausal, provided that premenopausal women are given ovarian function suppression. So we suppress the production of estrogens. Usually the ovaries initially are the most important. So either we do LHRH analog, these are drugs that suppress the production of estrogen by the ovaries, or we do oophorectomy, or radiation, but radiation therapy is less effective to suppress the ovaries. So those are the options. So nowadays we say we suppress the ovaries and we treat them like postmenopausal women. And this is the option, CDK4/6 inhibitors plus tamoxifen or aromatase inhibitor with the CDK4/6 inhibitor and ovarian function suppression. Now, if the patient progresses after use of aromatase inhibitor, prior hormonal therapy, then the option is a CDK4/6 inhibitor with fulvestrant, which is a drug that degrades the estrogen receptor. An important statement for research now also is that we recommend ABC4 guidelines. We recommend that clinical trials for hormonal therapy for hormone receptor positive, HER2 negative breast cancer patients should also involve premenopausal women, because young women are an important subset. Lots of young women have breast cancer and may have metastatic breast cancer. So we should have the option of enrolling them with clinical trials and give them the treatment along with ovarian function suppression. Another important expert opinion consensus statement is that CDK4/6 inhibitors should not be continued beyond progression. So if the patient has a progression on those drugs, we do not continue them. The patient should be changed to a different treatment. Those drugs are very expensive, and we do not have clinical trials that show that there is a benefit if you continue them. So if the patient progresses on CDK4/6 inhibitor, now we don't continue it, we switch to a different treatment. One important aspect is biosimilars. We spoke about biosimilars, drugs that are similar to the original drug, that we said that biosimilars should be, we are in favor of using biosimilars. We now have a biosimilar for trastuzumab, and we have biosimilars for colony stimulating factors. And they should be strict. There should be, pharmacological and clinical strict assessment and approval by agencies like EMA, the European EMA, or the American FDA, or other very strict association that they have been tested in terms of pharmacology, clinical efficacy, and toxicity. And we also recommended the panel that those drugs are really, the importance is financial because they reduce the cost. Therefore, we think that they should be substantially less expensive than the original drugs. What is important is to always recognize who is the patient who is candidate for hormonal therapy, that we can spare giving chemotherapy. We can delay the use of chemotherapy for a year or two, which is very good. It is important to know how to follow these patients and preempt side effects. Many of the drugs I spoke of are very well tolerated. Some drugs, like everolimus, are not very well tolerated, but we should have ways of preempting, assessing, checking the patient, following the patient, and making sure if there is a toxicity that we can prevent, we do prevent, and if it happens, we should treat it. Very important to make sure that the quality of life of the patient is improved.